Good evening, everyone. Today we are going to talk about intraoperative hypercapnia. And welcome to our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry, Sri Balaji Vidyapeeth, and my YouTube channel, Pain Free Partha. Intraoperative hypercapnia. So, what is it and why it happens? This is the base. Hypercapnia is the elevation of PaCO2 more than 45. This is simple. PaCO2, arterial partial pressure, carbon dioxide more than 45. Now we have two options. Either it should be produced more or it should be eliminated less. That's all. Increased CO2 production or decreased elimination. Simple thing. So very simple. Increased production is usually metabolic and decreased elimination is usually respiratory. That is what is the common sense. So when there is a decreased CNS drive, decreased neuromuscular response, increased dead space, so it's technically possible to develop hypercapnia throughout exposure in inhalation of environmental air-rich air in carbon dioxide. For example, now you are giving an environment where there is a hypercapnia. There is some rebreathing circuit. So it is also technically possible. So metabolic, respiratory. Metabolic means more production. Respiratory means something, decreased elimination. This is very simple. Now the second one is more important for us because faulty unidirectional valves, exhausted soda line, inadequate gas flow for a non-rebreathing systems, machine-related problems that lead to hypercapnia. You should understand the connections of the breathing systems. When we are bothered about this, sometimes hypercapnia can produce narcosis, sedation. Sometimes earlier stage it can produce sympathetic stimulation, tachycardia, hypertension. Even it can lead to arrhythmias. Okay, these are the problems intraoperatively we find with hypercapnia. Sometimes we find out, sometimes we do cases without ETCO. Sometimes rarely that is not functioning. Sometimes consistently your pulse rate and BP is raised. You check, there will be a bronchospasm. Connect PaCO2, then there will be 54. So this is how sometimes we may need to understand how hypercapnia causes problems in anesthesia. So we are dealing about PaCO2, more than 45 hypercapnia. So we are going to ABG and all these things. So what we have is ETCO2, non-invasive technique of what is there inside. So non-invasive technique. Now you see this is the capnogram. And here this is what we measure, end-tidal CO2. Here we measure to decrease the influence of dead space. So that is the reason why we measure the end-tidal carbon dioxide. Now there is a small difference. You see here the ETCO2 and the PaCO2. There is a small difference because of the dead space. Okay. Sometimes this is 35, this may be 38. The difference is due to alveolar dead space, which is small in healthy children that are ventilated but not perfused. This is very simple, understand. Now an alveoli is ventilated, but not there is no blood flow, not perfused. This becomes a dead space. What is the opposite? Alveolus is not at all perfused, but blood is flowing. That is what is called the shunt. Alveolus is ventilated, there is no perfusion, this is dead space. Alveolus is not ventilated, but going on perfusion, that is shunt. Okay, normally the gradient is between this is around 4 millimeters of mercury. What is the gradient? ETCO2 and PaCO2. This is what is called the ETCO2 gap. Increased dead space, if it comes, the gap is more. Sick lungs, the gap is more. Now we will go to professional way. Increase the production of carbon dioxide. There are a lot of non-anesthesia causes. Now we will focus on few things which happens in anesthesia. Sepsis, malignant hyperthermia, thyrotoxicosis. These are the conditions which can happen in anesthesia where there is an increased production of carbon dioxide. Hypercapnia caused by increased production of carbon dioxide is one thing, elimination decrease is another. When increased production of carbon dioxide, sepsis, malignant hyperthermia, thyrotoxicosis, laparoscopy, tourniquet release. These are the other two things. Directly capnoperitoneum and tourniquet release. So these are all the conditions intraoperatively which can cause increased production of carbon dioxide. Now sometimes your EtCO2 may not see. This is what is called volume capnometry. This may help. Normally it is around 150. Now you see the patient is in hypercapnia and atrial fibrillation. This patient denotes that this patient may be in thyroid storm. So malignant hyperthermia, see here, this is going on increasing with this slightly oblique things. Associated generalized muscle rigidity, hyperkalemia, hyperthermia, myoglobinuria, tachycardia. We get metabolic acidosis. This metabolic acidosis may not be there in thyroid crisis. Sepsis can contribute to hypercapnia. Now there is a difference. Systemic sepsis may benefit from hypercapnia. Pulmonary sepsis may be involved. Why a sepsis should produce hypercapnia? What are the reasons? Which sepsis should produce hypercapnia? Impaired gas exchange in the lungs, reduced respiratory drive, increased CO2 production. There are a lot of inflammatory response which can cause lung damage. This impact in case produced gas exchange deficiency. So that is the reason why sepsis can produce hypercapnia. Laparoscopy in spinal, sometimes capnoperitoneum, head down, high spinal, shoulder pain, some sedation. All these things cause hypercapnia in laparoscopies. Why laparoscopy? Spinal. Tourniquet deflation, ischemic lung, hypercapnic venous blood is into the systemic circulation. So apparatus may be the problem, conducting airways may be the problem, poorly perfused alveoli may be the problem. Now we have slightly gone into what are the metabolic causes or what are the causes which causes increased production, sepsis, malignant hyperthermia, thyrotoxicosis, laparoscopy, and capnoperitoneum, and tourniquet release. These are some of the causes of anesthesia-related increased CO2. Now we will go to equipment malfunction, where there is some problem in elimination. Leaks in bleeding circuits, problems in one-way valve, failure of the ventilator, the CO2 absorbent is exhausted. Sometimes what we do is the previous machines have bypass in that absorber. If you do a bypass, it will not go to the carbon dioxide soda line. And put it here, it will go into the soda line. So if you put a bypass and go into low flows, sometimes there may be a problem. There may be inspiratory valve. See here, this has to go here and ventilate. When it comes back, this should not allow. Valve is something that is something like cycle tube valve only. It allows flow of air one side and doesn't allow this side. That is what is called a valve. Now, if it goes through here also, everywhere this will be hypercapnia. And expiratory valve will go to have to through this. It allows here also and it will come here. So this is the problem. So this one-way valve is like this, then one-way valve is like this, then definitely there is hypercapnia. Here if you see slowly the increasing hypercapnia is there. Now the disc is gone here. Or sometimes your, see here, everything, disc is fine. If you go inside, this area is, now these are the one-way valves. Here the one-way valve looks normal, but if you see go down, inside if you see, there is a big leak. There may be change in position, neck flexion, endobronchial secretions. This may contribute. For example, if you do neck flexion, endobronchial it may go. First, it may be an decreased EtCO2 in endobronchial. And slowly the PaCO2 increases because one lung is ventilated. Here there may be an equipment malfunction here. Very common is soda lime exhaustion. It has come like this. So if you Unless you change, it is not going to be useful. Otherwise, you have to increase the flow to your normal. This is what DF. High CO2 will increase. Inspiratory carbon dioxide will slowly increase. And also the EtCO2 will increase. This is exhausted soda lime. Commonest cause of intraoperative hypercapnia, exhausted soda lime. Everyone will have. Notice this. The most critical point is if high, inspiratory CO2 is high. There may be problem here in the circuit. There may be disconnections here. See here in main circuit and also whatever be the type of coaxial circuit. Now, there are a lot of controversies about can we keep some hypercapnia, because this hypercapnia has got one advantage also, and I'll tell later. So there is some hypercapnia that I say yes, it is okay, but may not be good for the PGs. Everything that use established forecast. This is, for example, main circuit is for controlled ventilation. Manual circuit is for spontaneous ventilation. That and all we should not change. 140 ml of kg fresh gas flow, we can ventilate with 70 ml. And we have to ventilate with 140 ml for 70 ml fresh gas flow in this main circuit. Unless the circuit is fed, this is going to rebreathe. You need to give established fresh gas flow for each breathing systems. Now, we know what is dead space. Dead space is, for example, there is no gas exchange here in the trachea, all these things. Terminal bronchial. What is apparatus dead space? There in which there is a possible bidirectional gas flow is there. Now you see here gas is coming. Here gas is going out. There is no bidirectional flow here. But till here, bidirectional flow is there. This is normal. Apparatus dead space is very small. Now, if you want to do an MRI, and if you want to extend this brain circuit here, and the whole thing will become apparatus dead space, where we will find hypercapnia. Similarly, so this is apparatus dead space up to Y piece in circle system. If you extend like this and keep the patient here, then the whole thing will become apparatus dead space. But yes, if you want to increase the length of the tube, increase here and not here. Here and not here. So bronchospasm is one of the commonest cause, just like severe obstruction will go like this and slowly the patient goes into hypercapnia. There are a lot of other causes like kink to the tubes like this. You can see prone position, sometimes the kinking is here. Endobronchial intubation is very important here. Increase the airway pressure, but sometimes decrease the EtCO2. The EtCO2 will be decreased. That space is more. So arterial PaCO2 is important here, and that is increased. And hypercapnia will ensue. What is permissive hypercapnia? In which this is a ventilatory strategy. Avoid tight hydrolins, lungo distension, ventilator-induced lung injuries. Yes, maintain around 45, 44, something like that. 45, so permissive. Bore effect and better oxygenation. Hypercapnia will, what is Bore effect? Hypercapnia will cause oxygen delivery better. Shift to the right, oxygen delivery better. Affinity is less, delivery to the tissues better. That is one of the reasons. That's what I told. Hypercapnia sometimes may be better in outcomes, but it is not for the postgraduates. Intraoperative end-tidal concentration target. What is the actual target? Around 40, 35. But sometimes they say around 40 or higher also. That is what I told, better oxygenation. We will not know sometimes. Bradycardia and VPCs may learn earlier. That's what I told. Arrhythmias will warn because EtCO2 may be confusing. If you do a PaCO2 only, it will change. Delayed trans anal endoscopic microsurgeries. Now there is something called early PEEP. Before the creation of pneumoperitoneum, you create a PEEP of 10 centimeters and then do a lap chole. The incidence of hypercapnia is less and hemodynamic effects are better. Sometimes your thing will not be, for example, your EtCO2 will not be clear, but Think of the graphs. Is it going? FiCO2 is high. All these things. Think of the graphs. So people are worried about what is the respiratory change, fine anesthesia, gynec laparoscopy. We have another study which tells, yes, definitely EtCO2 increases from 31 to 38, but recovered fast. There are no clinical problems. This is what it tells. Now, what to do after seeing this? Check ventilator. Hang ventilate and start if you think there is a fault in the statue. Do an ambu bag with oxygen. Open up the drapes. See what is happening to the tubes. See chest expansion, air entry. Slightly increase FiO2. Check circuit soda line and thyroid, inflation of lap, deflation of tourniquet, start hyperventilating. See the temperature. So this is how we need to approach a patient with hypercapnia. There may be postoperative hypoventilation, intrapulmonary airway obstruction, splinting because of the pain. All these things will lead to postoperative common causes. Patient is not breathing. Patient is not recovered from neuromuscular blockers. Patient is not recovered from sedation. We have given intrathecal morphine, something like that. So there may be sometimes splinting due to pain. Soda bicarb is not much used nowadays, but the problem with those days was soda bicarb, if you give, it will generate carbon dioxide unless you have good ventilatory. Now, if the patient is on ventilator, we are ventilating, it will remove. But sometimes if the patient is spontaneously breathing, high soda bicarb may result in hypercapnia. Now, hypercapnia is increased more than 45. EtCO2 is usually less because of the dead space by 3 to 4 millimeters than PaCO2. It may increase because of increased reproduction or decreased elimination. Sepsis, laparoscopy, thyroid storm, malignant hyperthermia, tourniquet release are some of the clinically useful intraoperative scenarios. Circle system. In circle system, soda line exhausted. Unidirectional valves gone. Ventilators creating problem. These are all leaks. Leaks in the corrugated tubes. In maple systems, what is more important is the flows. Leaks and breaks are there, but flows should be enough to maintain this. Thank you very much. Visit my channel, Pain Free Partha, and also visit my website, painfreepartha.com for slides.